the rest is history, so to speak. So.
That's great. So good to have you with your expertise. And, you know, these are such amazing times. Was it in the early 90s, Doc, when, you know, pills like Prozac, sort of got a pillow issue here, started reaching their apex, and it was like, people made a joke, Prozac for everyone, you're in a bad mood, et cetera, et cetera. And then through the years, you hear about additional antidepressants that when someone is diagnosed, they can do talk therapy, but they also might get put on some antidepressants. And some work for others, but not for some. And I've heard of people going for months and years trying to get the right dosage and the right prescription. And could this brain scan help all that?
Well, the brain scan studies are really kind of like the very beginning studies of it, and they're comparing brain functioning, how it looks at through the scan itself, what, for example, a baseline, a normal happy person's brain looks like versus someone who's not in a happy place, and then someone who's on these antidepressants. And supposedly the goal is in this that we'll be able to start identifying what are some of the key signs. When you start taking the antidepressant, are there going to be preliminary signs in your neuroactivity that's going to say, hey, this is going to work for them? Now, if we start comparing that with some of the other stuff that's out there, for example, we have DNA testing that actually looks at receptor sites in your DNA makeup to see if maybe you have low epinephrine receptor sites. Norepinephrine is a key neurotransmitter involved in depression. So if I give you an SSRI, a selective serotonin reuptake inhibitor, such as Prozac, it's not going to increase the norepinephrine. So if your DNA says that you have a shortage of receptor sites in norepinephrine, then I need to give you what we call an SNRI, which increases the norepinephrine. So if we start using these things in combination, it's going to get us a better picture of what's going to work for each patient. And it's important to realize that those neurochemicals, you know, our brain is encapsulated with this special membrane to keep viruses and bacteria from getting in there and causing some sort of brain fever that could be fatal for us. So this membrane limits what can go in and out of the area around your brain, your spinal cord. So to test what's actually missing inside that area is potentially harmful for you, because we have to do a lumbar puncture. We have to puncture that membrane, and that becomes a permanent hole that now pathogens have an access to your brain. So we don't want to do that. Another way to do it is to measure exactly over a certain amount of time, 24 to 48 hours. We usually hospitalize people for this. We measure exactly what they take in, and then we take all of their waste products and we measure them for things like leftover parts of serotonin and norepinephrine to tell us how much your brain's actually making and things like that. That's very problematic. It's cumbersome. You're having to take a couple of days off of work. You have a very limited diet while you're in there because we don't want anything to contribute to getting false readings. And so we don't do it. It's very expensive, and the results aren't 100% perfect. So having multiple ways to start looking at brain functioning, whether it be a functional MRI plus a CT scan plus the DNA, and you add all that analysis together, that's going to give us such a better picture. In fact, with the DNA, I've already seen such dramatic changes when we couldn't find a medication for my patient, and the parents went out and paid for this DNA testing, and the testing came back and recommended an antidepressant that the psychiatrist and myself had never even considered for this person. We put the person on that antidepressant, and it was like night and day.
Wow.
Literally within 24 hours, this person was saying, he actually called my office and said, I feel normal for the first time. I've never felt this way before.